we have the embarrassment of the riches now because there's so many new drugs that are available, and we already have made tremendous progress. But to that, we add drugs that either add convenience, depth of response, or completely new mechanisms. So, and you may have heard from other presenters, we have Ixazomib, which is an oral version of a proteasome inhibitor, which in my mind, anytime people are using bortezomib right now, Ixazomib is going to be right there as an option for patients. We have Elotuzumab, which enhances the activity of lenalidomide and dexamethasone, will be used. And in my mind, anytime someone thinks about RD, they should be thinking about Elotuzumab RD. And of course, that depends, if a patient, for instance, is post-stem cell transplant and they are not on maintenance, that may be an ideal scenario for that. Likewise, the elderly patients who have usually better risk factors, those may be ideal candidates for ERD. But I think at this meeting, the biggest impact still comes from the anti-CD38 monoclonal antibodies. We of course have the approval now of Daratumumab, which is commercially available, and our centers are using it in a large number of patients. We did see data, of course, of the other competing antibody, Isatuximab. And not only as single agents, which they do have significant activity as single agents, but now very powerful combinations, for instance, with Lendex, with pomalidomide, dexamethasone. And I think it's easy to anticipate that in the not too distant future, whether it's the D or the Isatuximab or what have you, is going to be combined with multiple agents up front, try to build an R-CHOP equivalent for myeloma.